We now invite the panel members. We have a very distinguished set of panel members. So I would invite, Carolyn is the founder of the Prevent Cancer Foundation, one of the first really to focus on early detection and screening. Then Cheryl Healton, who's the professor of public health policy and management at the School of Public Health. She was the founding dean of New York University School of Global Public Health. Jacques Narula will be on Zoom. He's the executive vice president and chief academic officer at UT Health in Houston, and he's the president of the World Heart Foundation. And then Iskra Reic, she's the executive vice president international of AstraZeneca. So we have, let's see. Okay, my question to Bo is, what is the role of advocacy in low and middle resource countries, and how should they be organized to meet the needs, which are clearly very diverse in different countries?
Well, I think the biggest challenge in low and middle resource countries is that the advocacy movement is really not organized. I compare it to the way the breast cancer movement was working in the sort of late 80s and early 90s. There were organizations that were springing up here and there. Some were more, had an easier time raising money than others did, and were probably more effective. But this is sort of the situation in low and middle income countries these days, my experience. And my experience is really based on the perspective of the Global Lung Cancer Coalition, which many of you all know. We meet annually just before the ISLC World Lung Meeting. And there were about 4 of us who got together 25 years ago and organized this coalition. It's now grown to include 41 NGOs from 32 countries. And most of these NGOs are laymen, but some are actually professionals. They're physicians, they're oncologists, they're thoracics, they've got gynecologists, pulmonologists, and there don't seem to be any lay advocacy organizations in some of these countries. One of the most notable, for example, is Japan. We being the GLCC, conducted a survey in the spring of just this year, and 24 organizations responded, 4 of which were from low and middle resource countries. Those countries are Argentina, Bulgaria, Mexico, and South Africa. So a lot of my comments are going to be directed by the responses from those countries. And fortunately, we've got 4 continents represented. All 24 responses, though, span the gamut of sort of organizational structure, their kind of membership, their activities, which were mostly awareness campaigns, their resources, the availability of screening, and then just to drill down on that a bit, in 24 of these countries, 8 had screening available, and in 3 more, screening programs were being rolled out. Now, all screening programs are not the same, as you well know. In 2 of these countries, the screening has to be paid for by the patient or the screenee. In 5 of the countries, the screening program was for research only. In 6 countries, 6 more countries, screening is being discussed. And in 1 country, they reported absolutely no activity. And saying screening does not immediately, you might think it implies LDCT, but it doesn't. 18 of these programs are chest x-ray only for screening. So again, if we look at the 24 responses, half said the general population were not very informed, and 4 said the general population is not at all. So this is worldwide. This is not just low and middle income countries. 56% said that there's so much stigma around getting screened, and only 8% said there's no stigma. 3/4 of the countries offered to help a smoker quit smoking when that individual went for a screen. And 20% reported that they don't know any organizations that play a role in screening. So that's 1 out of 5 of all these organizations that belong to a global coalition focused on lung cancer. Now, getting specific about the 4 low and middle resource countries, Argentina, Bulgaria, Mexico, and South Africa, the approaches to screening vary widely. There's some general themes. There's low awareness of lung screening as a way to detect early stage lung cancer among both the public and the primary care community. Each country has only one lung cancer patient advocacy group. All these large countries, only one patient advocacy group. And none of the programs of these advocacy groups prioritize screening. So that is a great way, opportunity for growth. And I can tell you that I go to the GLCC meeting every year, and every year I raise my voice about screening, and it falls on deaf ears in many cases. I've even gotten Claudia and David to come and present at the meeting, and I don't know how much progress we made after that one. Also, even if there is general awareness, there's so many barriers to getting screened. First, the cost, the lack of insurance, the distance to screening facilities, and the availability only to those participating in research studies. So again, it harks back to the mammogram wars of the 1980s and 90s. I think that the final thing that I'd like to point out is, even though we heard from the previous panel that there are scanners and there is good equipment, there are supplies. In some countries, and I reference in particular Mozambique, where I know someone who runs a cervical cancer program, she said that the scanners in Mozambique are used only for treatment purposes, for monitoring treatment. There is no screening using CT scanners. So I seriously doubt that Mozambique is unique. I think the bottom line I'd like to leave you with is we have a long way to go, even in educating the advocacy community that purports to be lung cancer specific advocacy. Thank you.
Thank you. So we have many long ways to go, but you're going to help everybody, right, Bo? So Cheryl, it seemed like what is the smoking status in low and middle income countries? It seems like there are also more cancers in never smokers. So what should we, and how do we stop smoking from increasing?
Well, it's interesting. This is not working. Over the coffee time in this morning, I'm still trying to clarify actually trends in global distribution of smokers because the data are all over the place in some official public health reports. And I think it has to do with the change in the status of China from being a middle income to being a high income country. I think that shifted the numbers and is confusing the data. But let us simply say that, one, there are many, many smokers in low and middle income countries. And in many of those countries, the rates are rising. And in some, happily, they're falling. The strongest tools, as I think most people in the room know, to reduce smoking, to lower the overall population smoking rate are those strategies that stop people from starting in the first place or heavily induce them to quit. So starting in the first place, not starting, public education, taxation, clean air laws, and those I think are absolutely key strategies and appropriate policies that you can always count on the tobacco industry to fight. They're fighting even now, for those of you who were watching what was happening with the global non-communicable disease resolution at the UN meeting recently. The language on sugar sweetened beverages and taxation for alcohol and tobacco products was gutted, and I don't believe put back, though there was some hope that it might be put back in the full assembly. So we take one step forward, two steps back often. And we have a world that's activated around tobacco. Most public health people in the world know that it is, if not the number one killer in their country, close to the number one killer in virtually every country in the world. And so the strategies that are the cheapest and most effective are primary prevention. Try to stop populations from starting in the first place. And then after that come the strategies to help people quit. And many of the same strategies that help young people and others not to start also help people quit. If there's nowhere that you can smoke, including indoor areas, your own home because of regulations in your city, parks because you don't want to ruin them for others, eventually there becomes no place to hide, shall we say. And if the price is going up and up and up, for example, taxation programs that index to inflation or better, which is not common, would be a great improvement because they would lower the smoking rate. And then failing in all that and setting aside air pollution and these other causes of lung cancer, it is, in my opinion, ultimately crucially important that we implement comprehensive cessation programs in everywhere and comprehensive screening programs. This is why I was so excited in the most recent meeting, actually, I think it was Spain, when we talked about the way the costs could drop with AI interpretation. And there was a lot of excitement from countries around the world that they might be able to make the policy case for screening more effectively in view of that.
Thank you very much. Okay, next, Jagat, can you hear us?
Yes.
Okay, so how do we integrate cardiovascular screening with cancer screening and other lung health screening? Any suggestions?
A very tough question, Claudia. And specifically, as Cheryl just mentioned, about the Mozambique and other places, like we do not have the resources, the infrastructure is not there. And as you know that, I mean, we cannot even provide the essential list of medications at this point in time. We have been talking about the antihypertensive medicines, and you would not even believe that on top of 4 antihypertensive medicines, if I want to add a statin, only 2% of the low income countries would be able to afford that. That is our level of the health infrastructure in the low income countries, and we really have to think hard as to what would be the right way of doing that. Now, combining the heart and lung, it makes an absolute sense. I don't even know why heart and lung are considered as two different areas. Remember those days, just before I trained in cardiology, cardiology and pulmonology were one fellowship program. I mean, we are interrelated. Risk factors are same, specifically when it comes to smoking, and there is a lot being said about smoking here. So one of the most important areas, even the lipid levels, cholesterol levels, as the basis of coronary disease and that of the cancers, it's a significant relationship. Obesity, metabolic syndrome, so many things that we talk about. But the most important thing that we have to think is that cardiovascular disease is the number one killer, with 20 million deaths that were seen in 2022, with cancer responsible for about 10 million deaths, and chronic obstructive pulmonary diseases, about 4 million deaths, and lung cancer, about 2 million. So 20% of the cancers are lung cancers. Now, to have these 2 million lung cancer deaths, to be very exact, it was like about 1.8 million cancer deaths. Approximately 18 million to 36 million people would need to have the lung nodules. As 10 to 20% of the nodules would become malignant, and many lung cancers are not directly linked to the nodules found incidentally. So, however, this is a theoretical conversion and does not account for many people with malignant nodules who are never diagnosed, or the large number of people with benign nodules that do not turn cancerous. So, given all those limitations, there are approximately, let's talk about at least 20 to 30 million of people that will need to be screened. And if we can use these people just to identify the coronary artery disease, I think it is going to be a big deal, at least for cardiology, and the other way around as well. But most important thing is that if you look at the people who need the lung nodule screening, and you are the pioneer in that, uh, most of them would be at least the intermediate risk for the coronary artery disease, the only one indication where the coronary artery calcium score is to be done. I just fail to understand why do we not do that. And there are ways now that we can use the AI algorithms. The generative adversarial networks have been used, where they have created that even with the ungated lung scans or ungated thoracic scans, we are able to identify the coronary artery calcium scores. So essentially, there is so much of a relationship between the two that it makes a perfect sense that we have got to go with the screening together when we talk of the lung scans versus the cardiac scans. At least, I mean, as long as the coronary artery calcium scans do not become more popular or more widely available, we must use this opportunity to at least screen the people, or at least look at the coronary artery disease prevalence in the people who are being screened for the lung cancers. So I think CVD stands to gain from the low dose CT scans, ungated CT scans, and I think the winner here will be the cardiovascular disease if we are able to follow the algorithms in the lung cancer space. So I think it is no brainer. All the cardiovascular institutions, organizations, advocacy, they have to be supportive of the lung cancer screening programs so that the cardiovascular disease could be a beneficiary with those kinds of scans. So I think that's how I would like to summarize it and say that we stand to gain more from the lung cancer screens.
You made a very important point that physicians started treating the whole body. And now we've diversified, so we need to get back to the concept of the whole person and looking at the whole person. So that is a very, very nice point. So Iskra, your name, as I understand, means spark. So how are you going to spark industry to really help in this process?
Thank you for the question. You really surprised me with the comment. So now you put the expectation high. So let me try to spark the discussion a bit if you want. And I think it's really important question because AstraZeneca is proud to collaborate with I-ELCAP for a very specific reason and conviction that only with the academic and private-public partnership, you can really change and impact healthcare and patient outcomes. And, in AstraZeneca, we truly believe that, delivering the medicine to the patient is equally important as research and development that we are doing. And if our science doesn't really impact the patient outcome, then it's a science for sake of science, and that doesn't really have the impacted value that we are seeking for. And therefore, I think that industry can really support and help what you are trying to do in probably mainly in two ways. First one is when it comes to the data, real world evidence data and validation of all the great technologies that we can use in screening nowadays is absolutely critically important for any guidance, standards of treatment, and at the end of the day, government policies that should drive the screening and the diagnostic across the globe. Recently, we published the study called CREATE that basically captured the data consolidated from the program between AstraZeneca and Cure.ai across the countries in Asia and North and Middle East Africa. And that study clearly demonstrates that using AI-driven X-ray or low-dose CT scan, doesn't matter, really predicts with a high positive predictability the high risk or high risk patients, and really help you to screen and filter those that can benefit from the early diagnosis and early intervention. And the second area where the industry can help is clearly, how you scale up the screening programs that we heard a lot, from all speakers today. I think that, if you think about using the programs and protocols like I-ELCAP has, and then help to build the capacity and infrastructure within the healthcare system, whether it goes from the protocols, the working with the governments, working with the healthcare systems on the ground, is where industry definitely has the tools and operational support that can really facilitate that. And only if you have the program that is, able to scale up, you can really make a difference. And only if you have a program that actually is cost efficient and takes into account the budget impact, that is critically important if we think about low, mid income countries, then you can really see the scalability and the implications of the program you are doing.
Thank you. So we have these outstanding panel members. Is there anybody in the audience who wants to ask a question? Goodness, not even you, David? Oh. Oh, okay. Wait, they're coming with the microphone.
Sounds great to listen the three different points of view of establishing lung cancer screening, the power of advocacy, the power of epidemiology, the power of diagnosing other diseases, and the power of the support of the industry and the relevance to establish lung cancer screening. Our goal in each country and in each region is to do more, and I would like to have just one phrase or a short sentence of each panelist. You can choose the region. It could be Latin America, it could be Africa, it could be Asia, as a recommendation for establishing lung cancer screening. Because, for example, in Latin America, we don't have advocacy. Advocacy is lacking in each country of Latin America. We have advocacy for other diseases, but we know nothing about lung cancer, and particularly about screening in our population, and epidemiology just the same. Latin America is such a heterogeneous region, and we know very few information about the reality. We have tobacco information, we have incidence, mortality by global camp, but we know nothing about the real, the deep situation in Latin America.
Then I will start if I have a mic. So let me answer your question by using Latin America as an example. I think you have two great examples, and if you can scale it up across Latin America, I think you can get impact. One is Brazil, where the government is actually looking how to fund the screening program, not for lung cancer only, but for many different cancers, by increasing the tax on tobacco. And this is the plan that is currently in place, and the implementation is expected literally as we speak. So I think that's a great example how you can really make a difference, or at least make a great starting point. The second one is El Salvador, where the government is actually very forward-looking in implementing something, Claudia, that you mentioned. It's a comprehensive screening, how you can make it kind of more efficient and more, kind of with a less budget impact. If you really think about all different diseases, from lung to cardiometabolic diseases, when you are doing the X-ray, an AI X-ray or CT scan, and they are basically using any chest ray that is initiated for whatever reason, and basically scan it with the AI agentic program to scan for many different diseases. I think those are the examples that are very practical, not very expensive, and with the right partnership between the experts like yourself, I-ELCAP, and industry and government, I do believe it's manageable.
I thought you were asking for two things, and I may have misunderstood, but let me start with the one thing I thought you were asking, is what would be the advocacy messaging in countries that lack any activity around lung cancer screening. And I think in not all, but virtually all countries of the world, lung cancer is the leading cause of cancer death. Very few people know that. In a job I once had, the vast majority of people with whom I interacted who were not in the field of tobacco control, if I said that lung cancer was the leading cause of cancer death, told me I was wrong. And a very famous woman kicked me out of her office and then later called me back 2 weeks later to apologize for doing so. You would know her name. I'm not going to name her, but I will say she was famous, and she chaired a major cancer organization. And that was the basis on which she told me I was unequivocally wrong, that breast cancer in the US was the leading cause of cancer death in women. So people just don't know this. And so a campaign that says we can't ignore the leading cause of cancer death, and you might even not say what it is for a while and then start answering the question. That type of campaign can be done with a grassroots kind of activity. It's been done on campuses, for example, to address very particular health problems by putting up a black print on white question and let that question exist for 30 days with no answer. And then all of a sudden the answer shows up and it sticks with everybody. So there are mechanisms. In terms of countries, the ones I'm aware of, and I could be wrong because I'm just generally aware of them, are South Korea and China making some real headway. China, I think, started earlier than Korea. But they're both implementing the kind of programs that you would see in the US. In China, I believe it's confined, and probably also South Korea, to quote, high risk. And I do think the biggest battle that one has is that if you were to ask an objective group of 100 very well-versed people on tobacco policy and treatment and said, where's the bang for the buck? They would not think it is in screening. And that's the problem, particularly in low income countries. And that's the battle you have to deal with. And that's why bringing the cost down is so key, and maybe narrowing the focus so you're not doing so broad a screening effort that it's eating into the dollars that would result in primary prevention if deployed.
So I wonder, Cheryl, I'm coming back to your point about South Korea and China. Who are the advocates? Are they professionals or are they just people, lay people?
The only answer I can comfortably give you is that in China, these decisions are made on a sub-regional level. And what I think happened is there was advocacy on a sub-regional level, whether it was provider or public, I don't know. And then it caught on, and then it became national policy. And someone in the audience may understand it differently because I'm not an expert. I wasn't expecting that question, so.
Steve, you had a question. No? Okay. David?
So I have been impressed in the past year or two where I've really heard about the enormous amount of screening that's going on in some of these lower income countries, Vietnam, Malaysia, El Salvador. I mean, they are managing to get large percentages of their populations with chest X-ray screening. I've also been amazed at how I think technology is going to become the great equalizer in this as well. You know, we talked about comprehensive screening. This is one of the themes of this meeting. The rate at which artificial intelligence is helping and what it can do in terms of making screening easier, lowering the manpower efforts. We have a facility in Ethiopia now that has probably the world's state-of-the-art management system, where it's going to be filling out the data forms for the radiologists, finding the nodules, filling out the data forms. So I think we're getting to that inflection point, and I guess the point I'm sort of trying to make is that each country, if there's a will to do it, is going to find how it fits best, and I think we have to sort of leverage their own initiatives, their own, you know, where they feel they can put their resources. I know I was told that Turkey is starting an enormous program with chest X-ray. I mean, to me, this is fantastic. And I think we just have to keep working with countries and promoting this. Jagged, I'm sure you know what's going on with all the cardiac work in these countries, but, you know, the natural fit, I think we really need to start emphasizing between these multi-organ. But that's sort of the main point I wanted to drive, is that I think we have to leverage what the countries want to do and what they feel they can easily accomplish.
David, I think you have nailed it. I mean, like you encapsulated it so well. I mean, specifically the risk factor assessment programs and things like that they need to do, and then the screening programs, how we can build upon them. I mean, the data specifically coming from these low and middle income countries, and obviously also adding the high income countries as well, specifically as you see from what has come from the Global Cardiovascular Risk Consortium. I mean, more than 2 million people data, which was just presented in New England Journal of Medicine, 6 continents, 39 countries. And they looked at the 5 risk factors and demonstrated that at the 50 years of age, if you start looking at the risk factors, you will be able to estimate as to what is the likelihood of having cardiovascular disease and death before the age of 90. It was twice as high if there were risk factors present, both in men and in women. And there was more than a decade shorter life expectancy at 50 years before 90 years of age, if you had the risk factors. And the 2 most important things that they demonstrated, that if you modified the risk factors between 50, 55 and 60. And the 2 major ones which were mentioned were the hypertension modification, which was associated with maximum increase in the disease-free life years, that there will be no cardiovascular disease or less cardiovascular disease if you modify the hypertension. But most importantly, smoking cessation was associated with the maximum extension of the life years free of death. Now, this is an important advancement here. Now, if we really start to look at it, I mean, although I fully understand that we will require a large number of CT scanners and we will require a large number of radiologists or image readers or things like that, and the numbers have been given by the WHO, which are unimaginable. But you so well said it that with the artificial intelligence now coming in, can we really start doing things which can create the algorithms? Now we have got the guidelines. What we need to do, we know that. But important thing is, how do we create the roadmaps for the implementation of them in the low and middle income countries, which becomes extremely important. Can I create some very simple algorithms, look at the risk factors, which anybody can identify, any health worker, any person involved there can do that. And China has been mentioned, multiple places. They are doing it so effectively. I've been working with the China Heart House recently. You'll be surprised that more than 80% of the people are able to get their angioplasties if they have heart attacks in less than 90 minutes of time. It is way better than United States of America or any other high income countries. Within 5 minutes, the doctor is at the home of a person, not the ambulance. The doctor is at their home within 5 minutes of the pain call having been received by the central station. Now, question is that if we really start to implement it properly, how do I do that? I just identify the risk factors. I simply do an electrocardiogram, which can be done now with the phones also, a single lead. It can give you a more than 50% likelihood of having a coronary calcium score positive or negative. And then can we really have the trucks or things like that? One truck is good enough for 20 districts or 50 districts or whatever else it is. And we are trying to create the imaging guidelines for the low and middle income countries on behalf of World Heart Federation. Would we be able to do that? Would we be able to do just simple, straightforward, ungated thoracic scans, which cover up almost every single thing that you can identify with the low dose? You can look at their bone marrows, you can look at their livers, you can look at their lungs, you can look at their hearts, you can do anything based on the artificial intelligence. And so much of data can be collected. The only thing we require is now a will. Even money will not be that much of a problem, or finances will not be that much of a problem with the kind of technology which is being developed. So you said it so well that certain places, I mean Ethiopia, Turkey, and some of the other places which are doing it so well. And you'll be surprised if I tell you that when the hypertension detection program in Bangladesh, 3 years ago when we started there, 18% of the people were controlled. Today, 58% of the people with hypertension are controlled in that country. You look at Philippines, more than 65% of the people have been controlled with the hypertension, where 1.4 billion people across the world suffer from hypertension. I mean, very small amount of advocacy and willingness on the part of the government. And that is the reason that when I spoke at the United Nations high-level meeting 2 weeks ago, my insistence was on the national action programs in these places. And what is needed is willingness. AI support has come with lot of promise, and there is a significant enthusiasm around it. I know the path will be winding. It will have to prove itself in the low income countries as it has proven itself in the high income countries. It will need to be continuously kind of revised, and could be the reproducibility will have to be seen and all. But I fully agree with you that the willingness is needed here. It is, the ways are there. The only thing we need is the governmental buy-in and the national action programs, which include them in the policies. And I do applaud the efforts that you are doing and you are pushing forward with, and that both the lung and the heart programs are going to take advantage of it together. So thank you.
Well, thank you. That was an outstanding panel session. We could continue for hours for discussions, but thank you very, very much.
Thank you.